Andrea Kane, and I am here with you at HSC 114 Medical Terminology. We're studying the Language of Medicine, 12th edition by Davy Allen Chabner. We are now on chapter 22, Psychiatry. This is week 15. This is the second lecture video for this week. You have a discussion on the stigma of mental illness for this week, and then you also have a weekly assignment and weekly quiz, and they are only on chapter 22. So that's why this one is important. Really quick, before I dive into this, I want to talk about next week. Next week is week 16. Hard to believe that we are there already, but yes, we are. For next week, you have a comprehensive review assignment, which is pretty much the same as what you've done before, to prepare yourself for a final exam. The final exam questions are all questions that have been on previous assignments or quizzes. So there's nothing new there. You've had every single one of those final exam questions before. So that's really all it is it's just gleaning questions from before and putting those into a final exam. You also have a final project, and that is in there about medical terminology storytelling. There should be plenty of details in there. If you have any questions, you can email me personally, and I'll gladly get back to you. And then there's an opportunity for extra credit, as well as a discussion looking back. So that is week 16, and this is your last lecture video. I hope that this semester has been really good, that you've learned so much, and that you're excited about moving forward in whatever field is of interest to you. And I thank you very much for spending time with me and for learning about medical terminology with me. It's been really neat to see your discussions and your interactions, and know that you're growing in your knowledge. So I just wanted to say I enjoyed being a part of it with you. So all right, let's get to it. If you turn in your book to page 862, 862, that's where we're going to start talking about psychiatry in your book. Before we get started too deeply in psychiatry, I want to talk to you, Our unit objectives are 9.16.1 through 9.16.11. That's 9.16.1 through 9.16.11. And as always, we're going to be talking about everything related to psychiatry. We'll talk about some tests, some terms. We'll talk about those who are involved with providing psychiatry care, symptoms, disorders. We're also going to talk about some psychiatric drugs, some categories and names of those. And so that's why chapter 21 before this would have been helpful to you if you had a chance to look at that video. If not, go back and just take a look. And then, of course, the combining forms, suffixes, prefixes, abbreviations, and understanding medical terms in their proper context. Psychiatry or behavioral health, that field, is really important. And one of the things that I'd like to just say up front is that mental health is just as important as physical health. And just as you would never tell a diabetic person not to take their insulin, you would never encourage someone who has mental challenges not to get the help that they need. It's just the same. There is an unfortunate stigma still in society that keeps people from getting the help that they need. Mental health is so important, and we see that now during COVID and the pandemic and how that has impacted people so negatively. Our physical health, our mental health, those are associated in us. And we'll even talk about that when we get into some psychosomatic issues that can occur. But just wanted to really emphasize having compassion on those who have any kind of illness, whether you're talking medical or physical or mental. We all have our challenges, and we all need help, and we need to encourage one another. Psychiatry is the branch of medicine that deals with the diagnosis, treatment, and prevention of mental illness. Some people that you might run across that are involved are psychiatrists, psychologists, and clinical psychologists. Psychiatrists are almost always MDs. These are medical doctors. They've gone through residency. They can also be osteopathic DOs. So whether they're an MD, a DO, they've gone through medical school just like every other doctor, and then they've gone out in a residency and specialized in the field of psychiatry. Psychologists and clinical psychologists, on the other hand, are master's degree level individuals, that they are the ones that are doing treatments, counseling, those types of things. And clinical psychologists, they're heavily into testing, doing assessments and things like that. Some tools used by psychiatrists include drug therapy, psychotherapy, psychoanalysis. Some tools used by clinical psychologists are psychotherapy, psychoanalysis, intelligence tests, mental processing tests, memory tests, and personality tests. And note that they're not only used by clinical psychologists or by psychiatrists. Primary care physicians definitely test some of their older patients for memory, to be looking for dementia. Neurologists often do some type of testing to see if it's something that has to do with the brain versus something that's a mental illness. So moving on to page 864. And actually, I wish they would have done a slide. I'm going to step back. On page 863, there are some psychiatric clinical symptoms. Please make sure that you are familiar with those terms, 863 to 864, and that you know what those mean, because you will get tested on those. I wish they'd had a slide on those, but that's okay. You can just look at your book and see what those are, but make sure you're familiar with those for your quiz this week. Hint, hint, hint. All right, so psychiatric disorders. This is where we get into, if you've ever taken a psychology class, you learn about Sigmund Freud and personality structure and all of that. I'm not going to get into that. But one of the terms that you need to make sure you understand is defense mechanisms. This is something that we all do to protect ourselves. This is just normal types of situations that we do to protect ourselves. You may often, though, see it in a little bit more of an extreme form, perhaps, in children who have been through abusive situations. It's their way of surviving those is to have these defense mechanisms. And sometimes these defense mechanisms go beyond what is considered normal. And I want to stop here and talk about this. This is one of the challenges with the field of psychiatry, is that the medical community has defined what is normal. And in some cases, some people have a very narrow view of what is normal as opposed to a wider view of normal. And so some of this really a lot of it depends on perception and what the perception of the definition of normal is. One of the ways that might make it easier for you to think about is activities of daily living. Normal is we can get ourselves up, we can care for our bodies, shower, bathe, brush our hair, comb our hair, brush our teeth, those basic things. We can dress ourselves. We can get ourselves from one room to another or one place to another. We can take care of ourselves, make a meal, take care of our toileting, take care of grocery shopping, take care of making sure we have clean clothes. Those are all activities of daily living. And most of these definitions are: normal includes activities of daily living. Abnormal is when a mental illness or an addiction prevents or inhibits those activities of daily living being carried out. So that might be a really good way for you to kind of think about normal versus abnormal that would tend to be in an illness category. So let's talk about psychiatric disorders. They fall into some categories. So you have anxiety disorders, bipolar disorders, depressive disorders, dissociative disorders, eating disorders, and neurocognitive disorders. Those are the main categories. There are others, but these are the main ones that we're going to talk about. Anxiety disorders are all characterized by an unpleasant tension, distress, troubled feelings, and avoidance behavior. And again, think about this. We all have unpleasant tension at times. We all have some distress. We all have some troubled feelings. And there are times when we do want to avoid others or avoid an activity. That's perfectly normal. It's when it reaches the point that you can't do your activities of daily living, care for yourself in a healthy manner, that it becomes a disorder or labeled as a disorder. So phobic disorders are fears, real or perceived fears, where it causes such an issue that someone cannot take care of their activities of daily living and care for themselves. And same thing with obsessive compulsive disorders, with recurrent thoughts, repetitive acts, rituals, those types of things. It's not so much that having some recurrent thoughts, or doing a repetitive act now and again, or having a ritual is a disorder. It's when, again, it interferes with those activities of daily living, with healthy self-care. Post-traumatic stress disorder, we see this a lot with people who have been in the military or who are in the military. But it can also be something as being in a very severe car accident, being a rape victim, or having been in a house fire, or having some kind of traumatic event in life that can all trigger PTSD. And again, it's not that we might not have a nightmare now and again, but it gets in the way of being able to get the sleep we need to be able to be healthy and do our activities of daily living. Generalized anxiety disorder, this is chronic anxiety that has exaggerated worry and tension. So even when there's really nothing going on, for someone to be tense or worry or be upset or be avoiding a situation or a person, it's a constant high level of anxiety, constant, and which obviously is not good for the body. And again, you can't do those activities. It interferes with those activities of daily living. That's what causes it to be a disorder. Bipolar disorders, there's a couple of different types of those, and this is where emotion is dominating the person's entire mental life. Bipolar disorder, what we're most familiar with, excuse me, my voice keeps going in and out, is alternating manic and depressive episodes. This is where somebody is high. They are flying higher than a kite. They are on top of the world. They're euphoric. They may be awake for a couple of days in a row on end, no sleep, because they have this incredible burst of energy. Maybe they go out and they do something excessive that they normally don't do, like shopping or gambling or what have you. And then all of a sudden, it's like somebody flipped a switch and they are deeply depressed, deeply depressed. And they go through this sharp cycle of manic, depressed, manic, depressed, manic, depressed. That is bipolar disorder. Cyclothymic disorder is someone who has a mild mania. It's where they might And for many people, it would be just a normal where they have a couple of really good days. They're not flying higher than a kite. They're not on top of the world. They're not euphoric. They're not up all night. But life is great. Life is good. Life is great. They're happy. They're bubbly. They're outgoing. They're doing their thing. You just see all that energy and positivity and all of that stuff. But it doesn't happen very often. And there's a lot of depressive episodes mixed in. That's cyclothymic. Then depressive disorder is there's no mania whatsoever. No hypomania, no mania. It is deep, deep, severe depression. This is where it hurts to get out of bed. This is where there's no interest in life whatsoever. Just emptiness, sadness, all sorts of things like that. So depressive disorders, these are prolonged emotion that dominate a person's entire mental life again. And we talked about depressive disorder, dysthymic disorder, but there's also seasonal affective disorder. And that seems to affect quite a few people in the Midwest. Not so many people down in South Florida where it's sunny and warm most of the year long, and there's palm trees and there's the ocean. This is, we have a lot of gray days. When it gets into the winter time here in the north and in the Midwest. We miss those sunny days. We miss the warm temperatures. And that can cause some seasonal affective disorder where we feel depressed. And it's the lack of sunlight. It's the lack of warm temperatures and things like that. Dissociative disorders. These are chronic or sudden disturbances of memory, identity, consciousness, or perception of the environment. This next phrase is what's critical. Not caused by brain damage or drugs. Not caused by brain damage or drugs. This is entirely mental. Not brain damage, not drugs. Just entirely mental. Dissociative identity disorder is where someone has more than one personality. And the multiple personalities take turns in terms of the person's life. Dissociative amnesia is when there's just loss of personal information, and a dissociative fugue is when somebody up and suddenly unexpectedly travels. You may have heard of someone who just up and left one day. They just left. And then they're found years later, they have a loss of memory. And perhaps they're somewhere across the country and all of a sudden they find them. They may have had this dissociative amnesia and fugue. Eating disorders. These are really serious. These can be life-threatening because of the physical effects they have on the body. I think most people have heard about anorexia and bulimia. Anorexia is someone who is constantly, relentlessly shrinking their body in some excessive way, whether that's diet, exercise, combination of those. When a person with anorexia looks in the mirror, they don't see the skeleton that they have become. They don't see that whatsoever. And so they've completely lost perception of what is normal, what is healthy, and they are so bent on just getting that weight loss. And so it's a horrible, horrible situation. Bulimia is where the person binges and then purges, whether it's vomiting, using laxatives or enemas. They binge, which they're overeating, eating all sorts of things, and then they make themselves sick. Or they try and eliminate whatever it is that they ate to keep their calories down. And again, these have such a toll, such a physical toll on the body, not to mention the emotional and mental pieces that go along with those. And again, people have died from both, so it's very, very serious. Neurocognitive disorders. These are disorders of abnormal cognition, and these can be related to the brain. They can be related to drugs. And then they can also be a sign of a mental illness, but they should not be, when you see delirium and dementia, It may be mental illness, it may not be. There are people who come into the emergency department in delirium from being high on drugs or from having an extremely high fever and being septic from an infection. There are people who have dementia, and there are all different types of dementia and stages of dementia. There are people who who inherit a hereditary kind of early dementia where it actually begins in their 30s or 40s. So these are abnormal cognition, but there's usually something else going on with them. This is when someone comes in delirium or in dementia, it means really needs to be addressed further to figure out what's at the bottom of this and how it needs to be treated. Neurodevelopmental disorders, these are issues that happen that somewhere along the way in the developmental process, something didn't happen, either whether that happened before someone was born or after someone was born. There's still a lot of research going on to understand more about these. Everything from intellectual disability and communication disorders to autistic spectrum disorders, ADD and ADHD, specific learning disorders like dyslexia, and motor disorders. And again, you kind of have to understand that these people may lead perfectly normal lives in so many ways. They may have found ways to work around their challenges. So even though they may have this label, so to speak, it's not necessarily something that you need to treat with drugs or that sort of thing. It may just be that these are something that they may grow out of, or they may need additional help with, that sort of thing. Again, it kind of goes back to that that definition of what is the range of normal, and how does it impact activities of daily learning. Some people with ADD and ADHD have minimal impact on their activities of daily living, especially once they're on a medication. There are some people with intellectual disabilities or autistic spectrum disorders that, again, they may be able to do so many things that they are so close to that arbitrary subjective category of normal. I think of a young man who with Down syndrome, who recently finished an Ironman competition, which is just, that's so cool. And obviously that young man, in order to be able to even qualify for an Ironman competition, he's easily capable of doing his activities of daily living. Personality disorders. These are an enduring pattern of thinking and behavior that is contrary to what is culturally acceptable. And again, who determines what's culturally acceptable? That would be a question I would ask. But anyway, this is the definition that they give us, so we'll go with it. These are usually pervasive and inflexible, have an onset in early adulthood, and leads to distress or conflict with others. So when you're thinking about personality disorders, and there are 3 clusters, cluster A, cluster B, cluster C, again, you're thinking about pervasive and inflexible, often onset in early adulthood, leading to distress or conflict with others. So cluster A is paranoid, schizoid, and schizotypal. Paranoid is distrust and suspiciousness. Schizoid is detachment, so they appear cold, aloof, indifferent to the feelings of others. Schizotypal, or schizotypal, whichever way you want to pronounce it, is discomfort in close relationships, odd beliefs, bizarre fantasies, strange preoccupations, things like that. Cluster B is antisocial, borderline, histrionic, narcissistic, and narcissistic. It's hard to pronounce that one with all those S's in there. Um, this is at the bottom of page 868 in your book, if you're still following along. Antisocial is a complete disregard for and violation of the rights of others. These people have no concern for anyone else whatsoever. Sometimes they don't even have a concern for themselves. They have absolutely no empathy. Borderline. This is where you have instability in interpersonal relationships, where someone alternates very frequently between being intensely involved and rejection. Intensely involved and then rejecting others. So the relationship is a constant minefield because you never know when you're dealing with someone with borderline personality disorder. Are they going to be all in or are they going to be all out? And they keep going. It's not that it's one or the other, it's that they keep going back and forth and back and forth and back and forth that causes the issue. Histrionic, this is excessive emotionality and attention seeking. These are drama queens. These are the people who thrive and are desperately in need of theatrics and outbursts and tantrums and being the center of attention, and everything is just so much and so significant and on and on and on. So that's where the conflict comes in. Then you have narcissistic personalities where there's a pattern of grandiosity. There's a need for admiration. They have a preoccupation with their own self-importance and fantasies of success and power. It's not that these people are important or successful or have power. It's that they believe they do and they need to be admired for it. And it also comes out with a lack of empathy. They don't really think about others. They do. It's all about them. It's all about them. So if you've ever met a person where they believe the world revolves around them, it's all about them, and they are the greatest thing that ever hit this earth, and everybody should be bowing down to them, you may have run into a narcissistic personality disorder. Cluster C is avoidant, dependent, and obsessive compulsive. Avoidance is exactly what it sounds like. Someone is so hypersensitive and they're so fearful of being criticized or rejected, they just completely avoid. Just completely. They feel so inadequate, they're so hypersensitive, they just completely avoid. Then you have people who are dependent. And not that dependence is a bad thing, but this is again taken to an extreme. This is someone who is so clingy and dependent that they cannot take care of themselves. They cannot make a single decision for themselves. They lack whatever confidence or whatever the situation is. They want somebody else to do it all for them. And they absolutely can't do it. It's, we all take times in our lives where we reach out and ask someone for advice or are seeking some type of reassurance. That's perfectly normal. But again, it's taken to such an extreme that these are people who just can't make up their mind. They can't make a decision on anything whatsoever. They constantly want somebody else to take full responsibility for them and everything that they need. Obsessive compulsive, we talked about a little bit with orderliness, perfectionism, and control, repetition, all those things. These people are just so inflexible. And again, it's not that it's bad to want to have orderliness or to be a bit of a perfectionist or to want to have control. Those are all kind of normal things, but it's when it goes to such an extreme that it impacts their activities of daily living and causes conflict with everyone around them. That's when it turns into a disorder. So what about schizophrenia? Oh, I'm sorry. Let me really quick talk. At the bottom of page 869, there's also sexual dysfunctions and paraphilias. I'm not going to address those, and they are not, I don't believe any of those are in your quiz this week. It's there for you to read and be aware of, but I don't think any of that is whatsoever included. And there's not a slide on it. So moving on to somatic symptom disorders. Hang on. Nope, I missed, sorry, schizophrenia. Let me do schizophrenia real quick. This is a chronic psychotic disorder that's characterized by disturbed thinking and disorganized speech. Sometimes there's delusions, sometimes there's hallucinations, sometimes there's abnormal motor behavior, whether that is a type of involuntary movement, or it could be a catatonic behavior where it's just so rigid, it's like they're a stone. And then there's some negative symptoms. Typically, those with schizophrenia have a flat affect, a diminished emotional expression, and they often struggle with an unwillingness to initiate purposeful activities. Schizophrenic people can present as being there physically, but not mentally or emotionally. That's that flat affect. It's like they're there, but they're not engaged. And it's just that they're in their own world. But anyway, this talks on page 869. It talks, there's a section in there about schizophrenia. So somatic symptom disorders, this is now page 870. Somatic symptom disorders are when your mental conflicts get expressed as physical symptoms. It can be anything like abdominal or chest pain, nausea, vomiting, diarrhea, palpitations, deafness, blindness, paralysis that are not explained by a physical or other mental disorder or by an injury, or not side effects of medications, drugs, or alcohol. It's just that this is how it comes out sideways. It can be an illness anxiety disorder where someone's preoccupied with having or acquiring a serious illness, whether that's for attention or whether they honestly in their mind have tricked themselves to believe that they have this and they don't. Conversion disorder, we talked about repressed conflicts then get expressed as physical symptoms, that maybe they're not getting along with someone in their lives and that comes out as headaches or upset stomach or things like that, that they don't have any other, there's nothing to explain it. There's no physical disorder, and it's not a side effect of a drug. It's not an injury. It's just, that's how that comes out. And one or more somatic symptoms that are distressing or result in significant disruption of daily life then makes it a disorder, somatic symptom disorder. Sorry, got to get that out there. All right, so substance-related and addictive disorders, you have psychological dependence to drugs or alcohol. You can have physiological dependence where your body is actually dependent on that drug or alcohol, and where withdrawal, when it's discontinued, causes major problems. We talked about tolerance a little bit last chapter, in chapter 21 with pharmacology. And so your book covers this at the bottom of page 870. I definitely recommend that you go there. Now we talked a little bit about, I guess chapters 21 and 22 go together rather well when you think about it, because there's a lot of drugs involved with substance abuse, and there's a lot of drugs that are medications and drugs that are used in behavioral health. So the two really do go together. But on page 870 to 871 to the top of 872, it goes through some of the major substance-related types of substances that are associated with abuse, including alcohol, amphetamines, cannabis, cocaine, hallucinogens, opioids, sedatives, hypnotics, or anxiolytics. And at the top of page 872 is figure 22-3, and that lists some of those there. Oops, sorry, I didn't keep the slides going forward, should have. On the bottom of page 872 is table 22-1, and that's psychiatric disorders, where it actually goes through and gives you the category and then some examples of those disorders. And that should be helpful to you as you study for your quiz. Hint, hint, hint. All right, so therapeutic modalities. What can be done with psychiatric disorders and or substance abuse disorders? Well, there's absolutely drug therapy that has been found to be very effective. Psychotherapy in many cases is very, very effective. Then there's electroconvulsive therapy, and I'm going to talk about that for a minute. Back in the 1970s, that was really big, and it was used on a lot of psychiatric illnesses, and they did not have the science to back it up. Thankfully, ECT essentially dwindled to pretty much a stop in most places in the 80s. But in the early 2000s, they started back up researching it, and they found that ECT is actually very effective with some very specific psychiatric disorders. And so in the last 10 years or so, it has been brought back, but it's very carefully used now, and it has been so much more successful. So that is encouraging. Going back to psychotherapy, if you look on page 873 in your book, it lists all the different types of psychotherapy that are usually available. There's a short paragraph explaining what ECT is on the top of page 874. Just make sure that you're aware of what psychotherapy is, what ECT is, and what drug therapy is. On pages 874 to 875 to 876, it's going to go into the drug therapy, and this is important to know. I really like figure 22.4 or 22-4 on page 875. I think it's a very helpful graphic to show you the different types of drug agents that are used based on the type of psychiatric illness. And then it goes all the way over, and it does give you some generic names and brand names. And so again, this is in your book. This slide, just mentally delete it. I think they meant to put figure 22-4 from page 875 here, not this one. And they got that messed up. And unfortunately, because these are slides from the textbook company, I can't change them. Boy, do I wish I could, but I can't. So anyway, just FYI. All right, so on to vocabulary. Affect, amnesia, anorexia nervosa, anxiety disorders, apathy, autism, bipolar disorder, bulimia nervosa, cannabis, compulsion, conversion disorder, defense mechanism. Delirium, delusion, dementia, depression, dissociative disorder, ego, fugue, gender identity disorder, hallucination, id, labile, and mania. Mutism, neurodevelopmental disorders, obsession, obsessive compulsive disorder, paranoia, paraphilia, personality disorders, phobia, post-traumatic stress disorder, projective or personality test, psychiatrist, and it says here MD, but there's DOs. There are psychiatrist DOs as well, doctors of osteopathy. Psychologist, psychosis, reality testing, repression. Schizophrenia, sexual disorders, somatic symptom disorder, substance-related disorder, superego. Amphetamines, atypical antipsychotics, benzodiazepines, cognitive behavioral therapy, electroconvulsive therapy, family therapy, first-generation antipsychotic drugs, free association, group therapy, hypnosis, insight-oriented therapy, lithium, neuroleptic drug, phenothiazines, play therapy, psychoanalysis, psychodrama, psychopharmacology, sedatives, supportive psychotherapy, transference, tricyclic antidepressants, and then abbreviations. And there's lots of abbreviations here. And again, unless you really go into the psychiatry field or behavioral health field, you probably won't use hardly any of these. Combining forms. It's our root plus our combining vowel to equal our combining forms. Anxio, auto, hallucino, hypno, iatro, mento, neuro. Philo, or philo, depending on how it's pronounced. Phreno, psycho, schizo, somato. Notice the two there for mind, phreno and psycho. Some suffixes, genic, leptic, mania, phobia, phoria, and thymia. Prefixes, a, an, bi, kata, hypo, para. Fear of strangers is called. Klepto means theft or stealing or picking up. Agora means crowds. Pyro means fire. And that's all the hint I'm going to give you. All right, which of these health professionals has an MD? We just talked about that. I'm sure you remember. All right, an uncontrollable urge to perform an act repeatedly. This is where you truly can't control it. It controls you, not you it. All right, that's it. That is it for this chapter. If you have any questions, shoot me an email. Have a great rest of your week and a great rest of your semester. I wish you all very, very, very well for whatever it is that you pursue in life. I know that you will be a success, and thank you so much for spending this semester with me. Take care.